Ladies and gentlemen, welcome to the Grassroot Institute. It's great to be with you today in our presentation on why medical costs are skyrocketing in America, and we've got two of the nation's leading experts to talk about that. I'm Kaylee Aquino, president of the Institute, and I welcome members and guests who are here today at the Pacific Club. There's good news and there's bad news if you live in the state of Hawaii. Here's the good news. Hawaii has the most affordable health care in the nation. I don't know if you realize that. Our average premium is $675, the cheapest across the United States. We also have the best coverage. Hawaii mandates employers to offer full health coverage to employees. And that means that over 95% of adults and 99% of children are covered, making us the second highest coverage rate in the United States. And that's taken place for many years, and it's lasted for quite a while. It took a dip, however, when the federal government mandated the Affordable Care Act, and we're still trying to recover from that. But there's also bad news. And my guests today probably do not envy the fact that I'm going to tell you that they are up here to give you bad news. Healthcare in Hawaii has nearly doubled since 2008 in cost. Hawaii's state government now spends $1 billion every year on Medicaid, and the costs are rising fast. The rising costs of Medicaid and other insurance forms have resulted in and contributed to our unfunded liabilities. Those of you who have tracked Grassroot Institute know that we have told you that the employee retirement system for state employees is underfunded by $13 billion. But what you may not know is that the health insurance for state employees, a separate fund, is also underfunded by $13 billion. And the national costs for Medicaid, Medicare, and other forms of insurance are going to drive up the unfunded liabilities here in the state of Hawaii. So if you didn't think of listening well, you have at least one reason to listen, and that is your pocketbook is at risk. Because we're all paying for the costs of rising medical care. But with that said, I want to say that my two friends who are presenting today are optimists. Because they know that there can be a solution if government will listen. And hopefully we the people will help our government listen. David Hyman and Charlie Silver know their stuff. They really do. That's something that I've seen firsthand. For the past 3 years, I've participated in Cato Institute's National Summit on Healthcare. And these guys have distinguished themselves, so much so that I said, you know what? You got to come to Hawaii. And they asked, how much are you going to pay? And I said, nothing. But I'll give you a ticket to Hawaii. And so they asked their wives and said, okay, that's a good deal. So I'm glad they're here today. David Hyman is a professor of law at Georgetown University. Just wave it right now, David, so we know who that is.
The short one, yes.
Charlie Silver is a professor of law at the University of Texas as well. So, they are both scholars with the distinguished Cato Institute, and there is a book that they have published, and they're working on a second one. We have a copy of the first one here. Overcharge is what it's called. That's, in one word, the American healthcare system. Overcharge, why Americans pay too much for healthcare. And you can access their book and get a copy of it with their signature after the presentation today. We're going to listen to them for a bit, for another half hour or so, and then we're going to take your questions and your comments. Because we're broadcasting, members of the audience will need to come to the microphone over there to my right, and then you can state your question. But at this time, will you please welcome Charlie Silver and David Hyman. Give them a big hand. Take it away, gentlemen.
So thank you, Katie, and thank you to the Grassroot Institute for hosting us and the Pacific Club for giving us this wonderful venue. You can see the cover of the book here, and I thought we'd start with just a very short video that was made by the publishers to promote the book, to give you a sense of some of the themes, and then we'll talk a bit, show you another video. We'll start with diagnosis, and then we'll sort of end with treatment, because the book very much takes a medical approach to the problems of the healthcare system. So let's see if we can get the video to work. So the point of this is saline, which is salt and water, which costs about a quarter. Excuse me, can you hear it? No, that's somebody's phone. Which is probably better than my narration. But in any event, the point of this was you can make a bag of saline for about a nickel. It doesn't require much in the way of technology except for purposes of keeping it sterile. It's about as low tech as it gets. And if you look at what the various state Medicaid programs have paid for saline, they've paid up to $1,000 a bag. And so the healthcare system has sort of replaced the defense procurement industry as the source of scandals with government and sometimes private payers dramatically overpaying. And also people being overcharged, which is the theme of the book. So the basic organization of the book, you can see here, part 1 is 14 chapters that sort of identify problems with our current healthcare system and the problems that reform should have fixed. This is not primarily about PPACA or Obamacare or the Affordable Care Act, as it's variously called, except to the extent we identify problems that we think the current system has that particular set of reforms didn't do much about. And we draw examples from every sector of the healthcare economy, pharmaceuticals, hospice, surprise medical bills, which is something we'll talk about a little more. In our presentation today, we're only going to sort of skim the surface of a couple of the frauds and ripoffs that you'll find examples of in the healthcare system. And then part 2 turns to the treatment strategy, why past reforms have failed and what we think will succeed. And so there are 8 chapters that sort of cover the subjects that you can see reproduced here. And to sort of motivate the discussion and make it more concrete, we thought we'd show you just some relatively recent news articles about people who've been overcharged, okay? So this is from July of 2018. Family in Las Vegas goes to the gas station. The 9-year-old daughter is trying to fill up the tank. She gets a little gas splashed in her eyes. They flush it out at the sink at the service station. It's still burning, so they go over to the ER, which has a fancy eye wash station, which is broken. So they point her towards their sink. She rinses her eyes out, and off she goes, perfectly healthy. But they send her a bill for $800 for using their sink. Okay? $12,000 for a bee sting, right? To get an injection to deal with the bee sting. Emergency rooms sometimes have very large trauma activation fees. You can think of this as a cover charge for walking into the ER, the magnitude of which is completely disconnected from the cost or value of the services that you're receiving. This is my favorite example, also from about 7 months ago. This is a mother and a child from South Korea who go to visit San Francisco. The child falls off the bed in the hospital. Won't stop crying. They take them to the local children's hospital emergency room, named after a prominent tech zillionaire, and they treat the child with a nap and a bottle of formula and then send a bill for $18,000, combination out-of-network bill and trauma activation fee bill. Shockingly large for effectively treatment of no substantial value. This is a public school teacher in Austin. He's got very good insurance, right? Government employees, public school teachers, by and large, have very good health coverage. He has a heart attack. He is taken by ambulance to a local hospital, which is out of network. They send him a bill for $170,000. His insurance company says, we'll pay $50,000. The rest is on you. Okay, so think about getting a sort of, you owe us $110,000. You should be glad you're alive, but $110,000 after you've already been paid $50,000. Utah's a pretty conservative state, right? Utah's decided the strategy for dealing with high prescription drug costs is they're going to tell their public employees, if you're willing, we'll put you on a plane, send you to San Diego, bus you across the border. You'll buy your drugs in Mexico, bring them back, spend the night in San Diego. We'll pay you $500 for your trouble. This is not some, rapacious private company doing this. This is the state of Utah that's doing it to its public employees. And then something that just appeared yesterday, Walmart, when its employees need pricey problems, is paying to fly them to somewhere else to get a second opinion and let them decide what treatment they will require. This is somebody who had some neck pain. and a little bit of a tremor. The local surgeon said, "You need surgery." They flew him to a Geisinger medical center and they said, "No, you have Parkinson's. You don't need surgery. You need treatment for Parkinson's." Saved the patient an unnecessary surgery, saved Walmart a sizable chunk of money. Ask yourself the question, why is it that this is necessary to optimize the delivery of healthcare? So, and now I'll turn it over to Charlie, who's going to talk about everybody's favorite person, Martin Shkreli.
Everybody surely has heard of Martin Shkreli, yes? He was briefly the most hated man in America and the face, the poster child for pharma greed. Shkreli became infamous after he took over a company that manufactured a drug called Daraprim. Daraprim had previously sold for $13.50 a tablet, and he immediately jacked up the price to $750 a tablet. And this caused outrage because the treatment is for an illness called toxoplasmosis, which affects people with compromised immune systems, including sufferers of HIV. So the population that was in need of this pill was pretty well organized, and they were able to, as I say, single him out for greed. Shkreli really enjoyed the attention. He was not at all concerned, and in fact, after he promised to lower the price of Daraprim, he never did. It's still $750 a pill, and he actually boasted of, at a charity auction, he held a charity auction for the right to punch him in the face. And he boasted of getting a bid of $78,000. And when you see him smirking there, you say, I might pay that to punch him in the face. Shkreli was pilloried by the pharma industry. They said he's a bad apple. The rest of us are good people. So we shouldn't think of him as representative of the industry. But the fact of the matter is that Shkreli played an established game. Every pharma company in the country that sells drugs here has raised prices and used their control of the supply of medications to increase the price. So the game is very simple. Become the sole supplier of a medication, either by getting a patent on it or by becoming the sole seller of it as a generic, and then raise the price and see how much money you can collect. And so here are some examples. The first one on there is colchicine, which is a medication for gout and for a very rare illness, Mediterranean familial fever. And it used to be incredibly cheap, 9 cents a pill, but after a company got a monopoly on it through the Old Drug Act, they raised the price to $4.85 a pill. And the other examples are also common drugs that are off label, or off patent, and again, you can see how large the increases were. Branded drugs, which are drugs that are still on patent in some way, shape, or form, also have been selling for incredibly high prices. Consider insulin. As some of you may know, there's now a national crisis because people who are diabetics can't afford to get the insulin that they need. Insulin's been around since when, David? 70 years, something like that?
At least. Yeah.
Long time. It's not a new drug at all, but we only have 3 manufacturers, and they have figured out how to raise prices in tandem. So if you actually look at a chart of the price increases for 3 different drugs, what you see looks like one line. They are so closely tied in terms of price increases that they just go up step by step by step by step, and there's nothing that anybody seems to be able to do about it. Things are so bad that, go ahead David, next slide, that what we now have are the second annual, or the Shkreli Awards, which, I forgot what organization this is.
The Lown Institute.
The Loan Institute every year now nominates somebody to receive an award for pharma greed, and the example that won this year was the CEO of Novum Laboratories, who said that he raised the price of an antibiotic by 400%, from $4.75 a bottle to $2,400 roughly. And when asked why he did that, he said, quote, "I think it is a moral requirement to make money when you can." Well, so now self-interest and morals appear to be the same thing. So there you have it. The problem in the pharmaceutical sector is just one example, well known, of the problems in the healthcare sector. But as we show in the book, everywhere you look in the healthcare sector, there are similar problems, which I think we would generally put under the label of consumer unfriendliness. So what we see in the healthcare sector are sales of goods and services that do not resemble anything that we see in any other sector. Their prices are opaque, the service quality varies enormously, the prices for the same services vary enormously and bear very little relation to the costs. In many cases, the providers don't even know what the costs are. They just make up numbers. There was one hospital that was charging $50,000 for a knee replacement. And they wanted to find out how much it actually cost them to provide a knee replacement. And so they hired an efficiency expert to look at the whole process. And the number he came up with was $10,000. So they were making $40,000 in profit on every joint replacement, which is a level of profit I would like to make, frankly. So let's see, every kind of problem that you can think exists throughout the healthcare sector.
So it's not just those problems. It's also fraud and abuse, and waste is a sort of separate category that it's useful to separate out. We've sort of listed and have details about in the book each of these scams, for lack of a better phrase, where everybody from highly reputable, well-known publicly held companies and academic medical centers to fly-by-night fraudsters have taken the Medicare and Medicaid programs for hundreds of millions of dollars. Every year, the Department of Justice announces that it's going to crack down on the problem, and then it triumphantly announces that it's brought charges against these people, and it's recovered a record sum of money in fines and penalties. And then the next year, they basically could reissue the same press release, just with different names on it and slightly different amounts. It's basically a game of whack-a-mole, okay? And we sort of have listed all of the different entities that have gotten caught ripping off the system, ranging over time. And the last one on the lower right is organized crime, and that one sort of looks like an outlier. But it turns out it's not. Louis Freeh, back when he was FBI director, issued a statement in 1995 that cocaine distributors were moving away from their traditional business into healthcare fraud because it was safer and more lucrative than their traditional line of business, right? So the program is not really designed to make it hard for people to rip it off. In fact, in some ways, it's designed to make it easy because it prioritizes sending out checks as quickly and cheaply as possible as a way of ensuring that beneficiaries get access to needed care. But the downside, of course, is anybody who figures this out can take the program for hundreds of millions of dollars without a high likelihood of getting caught. Let me talk now about some of the people who did get caught, and we're going to focus on two physicians, the first of whom is Jacques Roy, who was a primary care doctor in Texas. And he discovered that there was money to be made in filling out forms that certified patients for home health care. The average physician fills out 1 to 2 of these a month. People who do geriatrics do it a little bit more often, and same for perhaps orthopedics, but by and large, this is not a regular activity. He did 11,000 over 6 years, 5,000 in a single year. He was the single most productive certifier for home health care services. If you did a plot of all of the doctors and how many they had certified, he was a sort of way outlier, and nobody noticed. Right? They just kept paying for the home health care that he was certifying. He gets suspended, but he keeps certifying and billing, and they keep getting paid because the fact that he was suspended didn't mean that the people who were cutting the checks were paying attention to whether or not you were an authorized certifier. He finally gets convicted in 2016 and it stops, but there are other examples we won't show you of people who went to prison and then started up new healthcare frauds while they were in prison to help finance their appeal of their original charges. Now let me talk a little bit about another issue that brings together a bunch of these themes. So wet macular degeneration is a disease that affects people's vision late in life. It can cause blindness if not treated. And Avastin, which is on the left, is a drug that was developed for the treatment of colon cancer. And turns out some people who were experimenting discovered that if you use this drug in people with wet macular degeneration, you could basically stop the disease in its tracks. And you could treat it very inexpensively, $60 a dose. Now, the drug company that was making Avastin was unenthusiastic about the fact that it was only bringing $60 a dose. So they came out with a different drug, identical, but tested for the treatment of wet macular degeneration, packaged in much smaller doses. That sold for $2,300 a dose. Okay? You would think if people were spending their own money, they'd prefer the $60 per dose to the $2,300. But doctors are paid historically 6% of the cost of the drugs that they're dispensing. So doctors had a big incentive to prescribe the more expensive drug, and many of them did. Okay, the interesting issue is how many did not, because it was not in their economic self-interest. If Medicare was structuring these things in a way that made sense, it would say, we'll pay for the cheaper drug. If you want the more expensive drug, that's up to you. But they basically left it entirely up to doctors. And some doctors went to town, one of whom is Dr. Solomon Melgen, a Miami ophthalmologist, who decided that every single patient who walked through the door had wet macular degeneration and needed to be treated for it. And on top of that, he quadruple billed for the doses he was dispensing. He got paid a total of almost $140 million by Medicare. Eventually, Medicare figured out there was a problem, and they started putting the screws to Dr. Melgen. He decided to take some of the money he had made and invest it in campaign contributions to influential senators. And Senator Menendez from New Jersey and his staff repeatedly went to bat for Dr. Melgen, a New Jersey senator going to bat for a Miami ophthalmologist, to try and get the Medicare program to give them back the money that they had taken away and continue to allow them to treat people. And in testimony, because both of them ended up being prosecuted, Dr. Melgen successfully, Senator Menendez missed trial. The chief of staff for Senator Menendez told the person at the Medicare program who was responsible for this particular dispute, bad medicine is not illegal. Medicare should pay these claims. Think about that. One federal employee is telling another federal employee, you should waste public money on bad medicine, right? So this is a theme that Charlie will come back to in a minute, of how medicine is affected by politics and politics affects medicine. But now we're going to switch gears and talk about surprise medical bills.
So in the recent election, healthcare was the #1 concern among voters according to various polls. Within the healthcare area, the #1 concern of voters was surprise or unexpected medical bills, with more than about 60% of the respondents saying they were either very concerned about surprise bills or somewhat concerned about surprise bills. To be clear about what surprise bills are, they are bills that patients receive after the amount that their insurance companies are going to pay has already been contributed. So they are balance bills. Has anybody in here received a surprise medical bill, by the way? We got a few people at least, including one of the cameramen. These bills can come from anywhere, although the most common source of surprise medical bills are emergency rooms, because they very often tend to be run by doctors who are not in the same insurance networks as the hospitals where the emergency rooms are located. These bills can in fact come from almost any provider. So we have examples in the book involving anesthesiologists who send out surprise bills. You think the hospital's in network, therefore your entire procedure is covered, but it turns out that the anesthesiologist is not in the network, and so you get a bill from some doctor that you met 5 minutes before the surgery for $20,000 that is not covered by your insurance. We even have one example where a couple went to a hospital to have their child, and the child had needed some time in the NICU, and after the child was sent home, they got a separate bill from the NICU because it wasn't in the same network as the hospital where it was located. This stuff is crazy. What we use to explain how crazy or show how crazy it is the example of a body shop. So all of you have been in one way or another in a fender bender, I assume. Everybody is, right? Everybody's been in a fender bender, right? So how does it work when you're in a fender bender? Well, you call your insurance company, you take your car to a repair shop, a body shop, they fix it, you get one bill, okay? And sometimes you have to pay your deductible, right? So you expect that, but as far as the other services, everything is neatly packaged into one bill. Typically it's at a reasonable price because body shops have to compete for your business, and that's the way it works. Well, a body shop is a repair shop that works on your car. The hospital is a repair shop that works on you. So why can one of those repair shops send out these kind of crazy bills, but the other kind cannot? And the answer, I think, is competition. And it is that if you went to an auto body shop and they sent you a surprise bill, for example, a separate bill by the fellow, the tech who painted the bumper on your car, you'd be outraged. You would say, this is crazy, I'm not going to pay this. You would tell your friends not to go to this body shop. You would complain to your insurance company, which would direct people to other body shops. And so this body shop cannot get away with this kind of behavior. But hospitals typically don't have to worry about a supply of customers, especially, for example, emergency room doctors. The customers come, no matter what the billing practices are, and so they don't suffer a loss of business as a result of being consumer unfriendly. So what we need to be thinking about is how can we increase competition? My understanding is that it's very difficult to do that here in Hawaii, because Hawaii has what are called certificate of need laws, which require somebody who wants to build a new medical facility to demonstrate that there is a need for it. And the owners of the existing medical facilities get to comment on that and explain why there is no need, and of course they don't want the competition. And so what we wind up is a situation where there's a lot of monopoly practices. Are we going to be able to see this, or?
We'll find out.
Let's see, this is our, do we have sound? Why do we have this kind of problem? One of the interesting things about this video is that the woman gave the urine sample as she was leaving the doctor's office and never even asked about the cost. Why didn't she ask about the cost? Because in the healthcare sector, we're all accustomed to relying on third parties to pay our bills. So at the point of delivery in the healthcare sector, the customer, you, the patient, pays about 11 cents on the dollar. The remaining 89 cents is paid by some third-party payer, which could be Medicare, Medicaid, the government, a private insurer, something like that. When you have a situation where we have extensive reliance on third-party payment, then the ordinary incentives of consumers to care about the costs are greatly diminished. And so we don't have the kind of shopping in the healthcare sector that we see everywhere else. And one of the consequences of that is that there's pricing opacity. People are often surprised about how much things cost because they don't ask about how much they cost in advance. And when they do ask, they still don't shop on the basis of price. So the system, the prices are completely out of whack in the system. If you think about it, we are really heavily over-relying on insurance in the healthcare sector. So how many of you have gone to the doctor and pulled out your insurance card and said, and heard that you have a $35 deductible or copay or something like that and just gone ahead and pay it? Well, the price of a doctor's office visit might be $100 in total. So why are we using insurance to pay for things that cost $100? Some of you have filled up your gas tanks and paid $100 to fill them up, right? And you don't use insurance for that. We don't use insurance for other kinds of routine things. And that includes things that can be expensive, like painting your house. We don't use insurance to repaint your house or to put on a new roof. These are things people pay for themselves. And insurance works best when it's used to cover catastrophes. Those are low probability events that incur high costs when they happen. So why are we using comprehensive coverage? Well, we're using it that way because that's what we've become accustomed to, and that's what things like tax incentives encourage. So we tax subsidize healthcare purchases, and as a result, the amount of purchasing goes through the roof, and as a result of higher demand, then the prices increase. So we shouldn't be surprised that we have a system where spending goes up and up and up, because in many respects the system is designed for spending to go up and up and up. It is exactly the opposite of a system that you would design if you wanted to control the amount that is spent and exert pressure on providers to charge reasonable amounts. David?
So we have a bunch of slides about single payer that we're going to skip past in the interest of time, but we're happy to talk about that during the Q&A if people want. And instead, we're going to close with what should we do? And this is the focus of the last part of the book. And I think our primary point is insurance is expensive because healthcare is expensive. And if we want to make insurance more available to people, to make sure people are covered against catastrophes, and we want to get a handle on the cost of healthcare, we should focus on the cost of healthcare, not on insurance, right? So we ought to focus on things that make healthcare cheaper. And market entry and competition, to the extent it's feasible, are the most useful and effective ways of doing that. They're not subject to capture. They're not subject to campaign contributions and bribes and the use of government power to keep out new entrants. And so that's what works in other sectors of the economy. We think it's an important tool here. We don't suggest that it will work for everything. We think there is a role for insurance for dealing with catastrophes. But for lots of things, different strategies are going to be helpful, including relying more heavily on self-pay. For branded pharmaceuticals, we think prizes are going to be a better strategy than patents. And for generics, the FDA has actually been an important reason why drug prices have gone up, and so FDA reform is here. We think federalism is very important, right? Different states have different preferences, different resources, different ideas about how they want to proceed, and we think different states ought to be given a lot of freedom to go their own direction. Hawaii's already gone its own direction. We think other states ought to do the same. We think we should fix the tax subsidies. If we're spending too much on healthcare, we shouldn't subsidize people to spend on healthcare. And finally, we think it's key that we subsidize people who are in need, but we should do that by giving them money, not by giving them health insurance. That's going to be an important factor in bringing more competition to the market. And so in closing, what we should avoid is building a road to hell based on our good intentions. Thank you very much.
Give a big hand to David and Terry. Good job.
Thank you.
Well, there's much more in their brains, and you can pick them now. All I ask is that you come to the microphone, please, right over there where Joe Kent is. Stand in line. Simply state your name clearly and get straight to your question. We'd like to fit in as many people to ask questions as we possibly can. Ma'am, aloha.
Aloha.
Tell us who you are and go ahead and ask your question.
I'm Marcia Joyner, and you skipped over single payer, and everybody that's in this audience, everybody that writes op-ed pieces, all want to know who and what and why single payer, and why did you skip over it?
So we skipped over it in the interest of time because we had so many things we wanted to talk about. But I think we can briefly highlight a couple of the points that lead us not to think single payer is a useful strategy. So the first point is, it's fine to say I'm in favor of single payer, but you should ask yourself, which single payer am I talking about? So if it's Medicare for all, that's very different than Medicaid for all, which is different than, say, the Veterans Administration for all. And the sort of public regard is highest for Medicare. The VA has been beset by periodic scandals, although it's also done a very fine job, depending on the time period you're looking at and the kinds of problems. It's a closed system, which is very different than Medicaid, which in lots of states pays very small amounts, and it's very difficult for people to get access to health care. So the first question you should ask is, well, what do I mean when I say single payer? The second question you should ask is, how are we going to fund the very large costs that are associated with putting all of this on budget? Okay, so the best estimate, conservative estimate, is this is an additional $32 trillion in new spending over the next 10 years. We already kind of spend the same amount already, so you're doubling the amount. You're going to have to dramatically increase taxes. I think the proponents are ready to do that. It's less obvious that the voters are. So 3 states, deep blue Democratic states, have flirted with single payer, and all of them have walked away from it when they got a look at the price tag. So if those states aren't prepared to do it, the sort of question you should ask is, well, why should we think doing it nationwide is going to actually go much better? I think the last point is single payer compounds the political control of healthcare spending that we talked about briefly and the book talks about in detail. these are healthcare decisions for lots of people are personal. They don't want their insurer telling them what to do. They don't want their employer telling them what to do. Why would they want the government telling them what to do?
Well, let me just add one other point. Single payer is usually sold by claiming that Medicare is more efficient than the private sector. And how many of you think, actually, that the government does things more efficiently than the private sector? I'm kind of curious. It's like, I rarely see that, but people believe that of Medicare. Well, they only believe it because they're thinking about the efficiency of Medicare in a truly dumb way. They take the total cost of Medicare, the dollars out the door, and they use that as a divisor with the administrative costs of Medicare in the numerator. And they usually say, oh, it's only 2 to 3% administrative costs. How could it be more efficient? What they're doing is actually giving credit to Medicare for all the dollars that are lost through fraud, waste, and abuse. If you actually took those numbers and asked yourselves, how much does it cost Medicare to deliver $1 in appropriate medical treatment to a patient who really needs it? Well, all the dollars that are fraud, waste, and abuse would have to go into the numerator. And when you put that there, Medicare is up at 20, 30 cents per dollar of appropriate care. And if you start adding in treatments that don't work, that Medicare pays for, and other inefficiencies, they're probably spending something on the order of 50 or 60 cents per dollar of appropriately delivered care. And so when you hear this argument that Medicare is more efficient than the private sector, really be suspicious that they're using a silly measure of efficiency.
Yeah, the book goes through this in great detail, and it's only $15.
Very good. Thank you, Dick. Go ahead and come to the microphone. Richard Morris.
Just as a matter of clarification, it's not Medicare that's inefficient because they're not doing the administration. It's the private health companies like United Health and others that are creating those inefficiencies. So we can't blame the legal act for the work. It's the people who are employed to handle it. Something about Hawaii that you might be interested in. Yes, we have some competition at the top in the medical field, but we're missing 700, 800, 1,000 basic doctors in our state because they can't handle the cost of living, which has to do with in part, with the lids put on by Medicare and Medicaid. We have an older state, and it depresses our ability to pay people to come for that.
That's a very good point. And when you see these proposals for Medicare for All, they often say they're going to save money by cutting the payments to providers by 30 or 40%. Well, that's not going to make that problem any better. Okay? Yes.
Very good. Thank you very much. Bill.
Thank you. There's discussion now in the high-tech industry of doing breakup or something to create competition, make things more efficient. Is there any formula that you might suggest in terms of the insurance company side or the medical delivery side that would give greater visibility to the financial extra profits made in certain segments of the company if you broke them into those smaller segments, and then you'd have a much better leverage? I'm coming from the perspective of having been a consultant to hospitals and have had the privilege then of seeing very detailed financial statements, how it was channeled to doctors, nurses, how it was debated within the boardroom as far as what's an essential procedure, which one gives us the most profit. Thank you.
Yeah, so I don't know the details about Hawaii, but there are lots of markets throughout the United States where we've seen extraordinary levels of concentration on the delivery side, healthcare providers, hospitals merging with one another and then acquiring physician practices. And then they basically cut sweetheart deals with particular insurers. The only losers are the patients. And so you need to deconcentrate those markets if you want effective competition, or you need new entry as a way of destabilizing these things. Some of them get so big they fall apart on their own because they can't sort of handle the internal tensions. The one set of doctors wants more than the rest are willing to give, and then people start abandoning ship, and suddenly your integrated system blows itself apart. I think effective antitrust enforcement is key in those things, but market entry is going to be more effective than antitrust, because unscrambling the eggs after there's already been a merger is very difficult to do. And so that's part of the reason why we talk a lot in the book about retail medicine and sort of direct primary care models as ways of moving away from a hospital-centric system, which makes it easier to engage in the tactics that you're talking about. On the insurance side, you know, the picture's more mixed, but you ought to worry about market concentration there as well. I think if you use insurance for catastrophic care, it's less important at that point, because suddenly the demand for insurance changes in important ways. It's no longer so critical whether you're in this particular network, and then that robs the insurers of their market power to dictate terms as well.
If I may, very quickly, you mentioned technology companies. One of the reasons that David and I are optimistic about the future is that we think technology is going to really drive innovation in the delivery of healthcare in the retail sector. It's already happening. So those of you who follow this industry know, for example, that CVS and Walgreens are greatly expanding the number of retail medical clinics that they offer. They're increasing the menu of services that they deliver. These clinics are located at convenient places. They have convenient hours. They have parking right out front. You don't have to make appointments very often. They see you within 20 minutes. Most of these places operate at least 1/3 of the time on a cash basis, so the prices are transparent. You walk in and there's a board and it tells you what the costs are for the different treatments. And now what we see are the tech giants that are getting into this in a big way. So Apple has watches that perform a variety of health services for you. That's going to increase. We have the consortium of Amazon, Berkshire Hathaway, and what is it, JP Morgan, that is trying to develop a new entity at the retail level. We really do see a lot of innovations, telehealth. There are just things I can't even think of off the top of my head, but these things are the future. And what they will do, I hope, is break up the local monopolies that the hospitals and other providers have and force them to compete and be more consumer friendly.
Very good.
Yep.
Thank you very much. Next, please.
Hi.
Tell us who you are.
My name is Ken. Thank you
Wow,
for
Ken.
your presentation. I had a question about, since you mentioned the different types of healthcare, so Switzerland has a hybrid model. George Halverson, which was the CEO of Kaiser for Europe, looked at that type of model and probably deemed it appropriate for the United States. What are your thoughts about that? Because I know that the population is different. I mean, they're contending with less things like obesity and other aspects that are here. But could that model necessarily work, you know, in kind of the public-private model where you still have that higher, you know, the coverage of most of your population? And then the other question is, could you just elaborate on prices as opposed to price?
So usually we get asked about Canada, and sometimes about Germany. This is, I think, it's the first time for Switzerland. Look, I think there are a variety of different models out there. Each country comes to its system for funding and delivering healthcare, partly based on historical accidents often, sometimes deliberate, but more often accidents. Each country has its own culture and the degree of expectations, people's willingness to wait in line. One of the slides that we skipped over as to why we don't think single payer is going to work nearly as effectively here, or for that matter, any country trying to impose its model wholesale, is if you think about our representative democracy, it provides lots and lots of opportunities for people to come in and say, yeah, I don't like that. Or I'll only do that if you buy me off. And you know, the people who don't like that call that special interests, and the people who do like it call it representative democracy. But the point is, it's difficult to imagine a sort of top-down imposition of a system that we don't have, unless federalism causes it to blossom in a particular location. The other point that the slide makes is our government often behaves as if it's run by idiots. And so, you know, imposing a system and getting it to work, implementing it effectively, is actually extremely difficult, as I think we've seen with the Obama administration's attempts to not do a complete redo, but to fit a complicated system into an existing complicated system. It's really hard. So we, in our book, talk about Singapore as a proof of concept of the way that we're suggesting the system ought to look. not because we think, you know, a small city-state is representative or applicable to our much bigger country, much more diverse country, but because it shows that a system that relies more heavily on cash pay can be implemented not in a top-down fashion, but in a bottom-up fashion, where people spending their own money make their own decisions. So that's, I know about Switzerland's system. I think it has lots of promise. It seems to work for them. But I'm hesitant to say this is the right model and we ought to do it nationwide. You don't say we think we ought to go have federalism if you think you've already got the answer for all 50 states. Oliver Wendell Holmes once said, if my job is if a state wants to go to hell, it's to help them get there. Now, you don't have to think that about our health system redesign strategy, but nonetheless, I think the idea that what works for Hawaii will work for North Dakota or California, and the same goes for what works for Switzerland. We ought to be more modest about our reform aspirations. If nothing else, our past history in trying to reform the healthcare system should make us hesitant to try and cram it down the throats of people who don't want it.
If I can briefly add to that, I'm a firm believer that the best predictor of the future is the past. And so when we think about what single payer would look like if administered by our government or any system like Sweden's, for example, the best indications are the way that the government has run healthcare in the past. And if you look at the cost spiral, you'll find that the cost spiral in this country began with the creation of Medicare in the 1960s. So ever since Medicare came online, healthcare spending per person has gone up and up and up to the point we are now spending slightly more than $10,000 per person. So that's the way politics works in this country. It's impossible to talk about rationing, for example, in politics in this country. It won't become possible to do that if we're under a Swiss model. So what we should expect under any system is that we will have a vicious cycle where there is more and more money spent on healthcare and then more and more money poured back into the political system by the providers to encourage spending more and more money. That's just the way our system is.
Thank you very much.
Yeah.
Now we've got 3 more questioners for us before we end today's presentation. I'll close off the line at this time. If the 3 would come forward and go ahead and ask your question. We'll ask for some brief responses. Go ahead.
Thank you so much. I've enjoyed this talk very much. There's a white elephant in this room.
Mm-hmm.
I'd like you to comment, if you can, on tort reform and how it relates to this issue.
You're talking to a couple of lawyers, by the way.
I understand
It's
that.
worse than that.
Yeah.
It's almost as if they have it on their foreheads right now. I'd like to hear what your comments are with respect.
Good question. Go ahead, Jim.
Take care.
Well, we happen to be 2 of the country's leading empirical researchers on the medical malpractice liability system and its ancillary effects. So we've published peer-reviewed articles, for example, on the connection between medical malpractice litigation and physician supply. Does increasing medical malpractice litigation drive physicians out of your state? We've often heard that that's true. Turns out to be almost completely false. We've also heard that medical malpractice fears drive heavy spending on defensive medicine. Our former Secretary of Health, what was his name, Price, put out this number that was something like $600 million or billion dollars a year in medical spending was traceable to defensive medicine. Well, our very careful peer-reviewed study of defensive medicine found no significant effect of the intensity of malpractice liability on physicians' prescribing and treatment practices. And our results are far from unique. Our results are typical of the findings of academics who study this. So frankly, my opinion is that medical malpractice adds about the total cost of medical malpractice premiums to the system. What's that, about $30 billion a year? Yeah, that's not even the tail wagging the dog. That's just nothing as far as healthcare spending is concerned.
So just very quickly, doctors routinely complain about liability exposure causing them to treat their patients in a particular way. And the way the studies work is you look at states that have enacted a cap on damages and you see whether doctors change their behavior. And multiple studies have found very small effects, if any effects at all. That suggests that doctors do the things they do for a bunch of reasons. Medical malpractice may be a very small part of it, but if you mostly take away, we don't have anybody that's completely eliminated liability risk, but pretty significant caps don't really seem to change doctors' behavior. And that shouldn't surprise you, okay? Doctors do what they do because they've been trained in a particular way and because they have a variety of incentives that encourage them to do a particular set of things. And on those lists of things, liability is not at the top of the list.
Very good. And now the good physician, Dr. Abby Wong.
Hi, my name is Abby Wong, and I'm a retired OBGYN physician. And my concern, I guess, is that whenever you hear presentations on the rising cost of medicine, nothing is really ever mentioned about the cost of litigation and malpractice and the underlying floor of, where medical costs begin. There's already a floor that it is established, I would think. I've never seen it, but I would think that is established to include medical malpractice, insurance, and litigation. And I've never seen anything, presented that shows what is this cost over time, and what is this costing people over time? Is this increasing over time? Is it being addressed by the Bar Association? I mean, what do lawyers, think about this, and how do they think about rating this in when you have awards to malpractice cases, $23 million? I mean, people think, well, the insurance company's going to pay for that. Eventually, we all pay for that because our premiums all going to rise because somebody has to pay the $23 million. And the $23 million is not going to be going directly, all of that money is not going directly to that patient. They're going to be paying attorney's fees, court fees, yada, yada, yada. So it's not like all that money is going to that victim. So I'm kind of frustrated hearing about the rising costs of medicine going into the future, and there's nothing mentioned, or there's nothing I've seen where there is an evaluation of the cost of litigation. How is that handled? How are you going to curtail that? Should there be caps? I don't know. But we need data, and I think that data is lacking, and I don't think there's anything addressed by this issue in your book. No. And I don't mean to be rude, but I know you both are attorneys, but that's an issue, a really big issue. Thank you.
You want to take a whack at that?
So I'm also a physician, but I'm a law professor, and my job is doing empirical studies of this. And I'm certainly sensitive to the reality that it's very expensive to run the medical malpractice system, and it imposes a huge cost on physicians who are sued, often with no result, right? People get sued and then the case goes away. So, I think our best evidence is that 75–80% of claims close without payment. Not all of those result in a lawsuit, but nonetheless, that's a very high tax, right? And it's a tax that's felt directly on doctors. When I teach medical students, I say to them, look, the worst thing that will probably happen to you in your professional career is getting sued for malpractice. It'll cause you to doubt the reasons why you went into medicine. It'll cause you to look at patients differently. Our evidence is that it doesn't dramatically affect people's behavior. It has some small changes. To the extent, we've built in high spending because of liability risk, that's certainly possible. What I can tell you, though, is the states that have capped damages haven't seen dramatic changes in their healthcare spending trajectory, neither the volume of services nor the price of services. The cost of coverage goes down after you cap damages. Some of that's going to get passed through to patients. The book is not really about malpractice. We have another book about malpractice that is in press if you really want to read too much about that subject. Last point, I think contract has more promise than the civil justice system of here's a package of rights to sue your doctor. You can exercise them or not. Patients don't want to sue their doctors, right? They want high quality care. Without errors, and they want to trust their doctors. And the liability system tends to be their last resort, and I'll stop there.
Well, that's a stimulating issue. We'll keep that open afterward. And finally, our last question. Please tell everyone who you are and go ahead and ask your question.
Hello, I'm Jacqueline Young, and I would just like to give voice to a dangerous demographic that is seen as such a liability to everybody. But
And Jacqueline, because of our time, can you make it very quick?
okay,
Thank you.
well, when Obamacare happened, my mom was working at Dollar General, but they cut her hour to 100 so they wouldn't have to pay her insurance. And I know so many people who work so many part-time jobs and don't have insurance at all and would just rather pay the fine at the end of the year. So maybe you have some numbers on what the impact of that will be long-term for those people.
Thank you for your question.
Yeah, this is the downside of an employer mandate, right? And actually linking health insurance to employment was the result of a tax subsidy decision back around World War II, which was just dumb, okay? And we should reverse it. We don't link any other kind of insurance to employment. Why should we link health insurance to employment? And when you do, you get these kinds of bizarre incentives, right? If I have to provide better benefits if you work more than a minimum number of hours, I suddenly have an incentive to cut your hours or to fire you entirely, and we don't want to encourage that, right? So what we should do is uncouple health insurance from employment rather than link it more tightly.
And the best thing we can do for those people is make healthcare cheaper, right? They don't have coverage, so they're price sensitive. So the thing we need to do is allow lots of innovations that make healthcare cheaper, and that way they'll have access to the treatments that they need.
Well, for David Hyman and Charlie Silver, give them a big hand.
Thank
Just two things I want to say. If you'd like a copy of their book, it's available up front, $15, cash or check, and they'll be glad to sign it for you. And if you were given one of these cards, we appreciate it if you would fill it out because we want to make sure that you receive our weekly publications that are kept informed of these kinds of events. Until next time, thank you for being here, and aloha from the Grassroot Institute.